Hi folks. Yes, Daryl Mabry's my name, from Australia, from Victoria. I wanted to talk about why the hell adult mental health workforce don't respond to families. Is really, that's the real title of my presentation. Today what I did want to do was give you a little bit of background evidence around that, but certainly some of our Australian research in this area as well. But then I wanted to outline a strategy that's been employed in our state, in our province, to actually try and do something about it, try to increase family-focused workforce work in adult mental health services. And it's a strategy that rolled out 5 or 8 years ago now, and then I'll talk about an evaluation of that strategy that we're employed to do. So we know 1 in 5 people develop a mental illness, and 21 to 23% of those of children are brought up in a family like that. We know particularly though that 20% of adults who go to adult mental health services or psychiatric services, 20% of them have children. All right, so now as you probably know, 15 years ago, well certainly in Australia, 15 years ago, nobody even asked if they were parents. And it was never even on the agenda. And we know from studies also that in terms of psychoeducation that families receive or children receive, that only 2% of families in a fairly large study in the Germanic countries actually received any sort of psychoeducation. So that means 98% receive nothing. I think that's a more telling statistic. And I do have a bit of a soapbox about this that I won't try and get on too much. Now, Australia's really no better than that. Really, Elizabeth Fudge years ago talked about children in adult mental health services being the hidden children, because they're just not on anybody's agenda. And you've heard that many times today. And up till recently, we didn't ask, are you a parent, do you have children? But then we've undertaken about 4 studies or 5 studies in this area over the last 6 or 8 years now. And during one of those studies, we came up with this idea of, well, what gets in the way of adult mental health clinicians doing that? And we developed this triangle, and it's in a paper somewhere that nobody ever reads. You know what I mean? So that's why I have to pull it out here and show people, because I think it's pretty neat. But one of them is that children have to want to engage. So the children have to actually want to engage or be there, or actually be around. Often children aren't there. They're off with a grandparent or another parent somewhere and can't be engaged. Also, the parent must be interested and must be able to engage. Often in a lot of our research we find the parent's too sick and can't be engaged about their family. One of the other biggies though is that the workplace must also support family-focused practices with policies, procedures and resources. Now, I think Victoria does a whole lot better than anywhere else in Australia probably, maybe not New South Wales, but that's a lot of work has to be done there before you can actually have the poor old adult mental health clinician who's sitting in here with adults' attitudes, knowledge and skills and so forth. So all of this has got to happen. I blame the poor old adult mental health worker all the time, but there's a whole lot of other stuff has to go on that's really, really important. And you need to think of if you're going to trying to make change in this area. It's not just about making them more skilled, knowledgeable and so forth. But I must say that's where a fair bit of our research went. And we look at profession differences and a whole range of things and skills and knowledge. We've spent a lot of time on a key thing for the actual adult mental health clinician is around confidence. And is around confidence to distill a lot of evidence. Really, we thought it was, they would say originally, oh, it's not my job. And then they'd say, I don't have the resources to do this. Our organisation doesn't have the resources. They've then moved on to saying, I don't have the skill and knowledge. And then from me being a clinician myself, when they started saying, I don't feel confident to work with parents about parenting, I don't feel confident to work with children, about child issues or about the parent about child issues, then I thought, I think we're onto something here. Do you know what I mean? So I think if you're talking about training, that's where you should be focusing the workforce stuff, to go back to this bit here. But the thing is, you need all of those in place to be able to work with kids, basically, and to intervene with kids, I think. So, what happened in Victoria was that the government decided that they really wanted to make change happen. They really wanted to make adult mental health workers change their behaviour and become more family focused. So they developed what was called the FAPMI strategy. Now, where are we talking about? Here's Australia down the bottom end, not the pointy end, and this is the state of Victoria. Now, it's the second most populated state in Australia, and it's quite close, like it's 9 hours drive, I think, from that point to that point, but that's pretty small in terms of Australia. So that's the state that we're talking about with the Families with a Parental Mental Illness strategy. In the early days in Victoria, we talked about COPMI, children of parents with a mental illness. In some studies that a group of us did early on, we turned that into FAPMI, families. We really focused the whole place back on families rather than children only. All right? The early studies we did were on peer support programs, taking kids out, doing something with them and putting them back in. But and there was real evidence we found. Kids would come back and parents would go, shit, what did you do? This kid's a monster now. They're actually being assertive and challenging me and have self-esteem and, you know, those things. So we then thought we need to work on the family here, because they were saying, how dare you do that? And they had a real right to say that. Hence we focused on family. We then wrote a paper on prevalence as well. Like, the government basically said to us, well, how many of these people are there? When we started putting numbers against it, they started to go, wow, this is a problem. This is an issue. And I'll show you more real numbers in a moment. The FAPMI strategy came into being in 2007, and we did the evaluation in 2012, 5 years later. What is the FAPMI strategy? It's around improving the skills of adult mental health clinicians. That's the first objective, to be family focused. The second one is to develop partnerships with local agencies so adult mental health work more closely together. And, that's the third one, but it also to increase the capacity of the two to work together, so community agencies to work together. Now, in Victoria there's 22, I think it is, health regions. So health regions that are across the state. 11 of them got a FAPMI coordinator. 11 missed out, and they're still not funded to this day. And those regions, with something like probably 300 to 500,000 people in the region, and I'll show you the numbers of adult mental health clients in each of the regions. So half of them got them, half of them didn't, and half of them still don't have them to this day. And some of the workers are not full-time. So we're talking about 11 people in 11 regions doing stuff in terms of those strategies I told you about before. Now, Mel Goodyear is here and doing presentations today, worked with us on the project, and we work really closely with a group called the Bouverie Centre, the Bouverie Family Centre, and that's where the actual FAPMI strategy is based out of. And so there's all these regional people out in the 11 regions from a coordinator that coordinates the process. So it started in 2007. Pretty busy slide, I'll help you look at this. So here we're talking about, here's the years, obviously. These are the non-FAPMI regions. These are the FAPMI regions. So we can see there's 35,000 adult mental health clients in the FAPMI regions, 23,000 in the non-FAPMI, all right? So in Victoria, there's over 50,000 adult mental health patients or clients or whatever you want to, each year. So, and that's pretty consistent. It gets up nearly to 60,000 by the last year of the data. This is the data from the Adult Mental Health Service, all right, that they provided to us. So how many with children? Well, here, out of these 35,000 total clients, there's 7,000 children, or just over 7,000 with children. And that equates to, in 2006-7, 21%, just under 21%, just under, above 21, and so forth. So it's around about 21% every year of everybody who's in adult mental health services in those regions who are parents with kids. You can see why the FAPMI regions, the 11 were chosen and why the others were not. Nearly all the others are much lower. So it actually chose their FAPMI coordinators on how many parents were in the regions. All right? So you understand that? So they're a bit different in the regions. So when I show you comparisons of data, but on average it runs about 19 to 20% across the board. All right? This is the number of family contacts that were recorded on the online system. Now, to go back a step, online data collection in adult mental health service, they say, is about 60 to 80% accurate. You know, there's a lot of people just don't fill stuff in. You know what I mean? So, and it's getting better and better and better, but that's what clinicians do. That's what I did. Didn't keep my notes up to date, didn't record stuff. You know what I mean? Keep that in mind with the figures. But you can see this is how many, on average, family contacts there were in the non-FAPMI regions and in the FAPMI regions. A bit more in the FAPMI regions, but we'll talk about this. I'll show you some data on that in a moment. So what did we do? We had a natural comparison group when we did an evaluation in 2012 to compare FAPMI regions versus non-FAPMI regions. So what we did, we looked at changes in referrals to and from family services over the 5-year period. So we basically said, well, okay, these guys are going out, they're doing all this work that relates family services and mental health, upskilling mental health, upskilling family services, but the two to work more closely together. Let's have a look at referrals from mental health to community services back to mental health. So that was one thing. We've also developed a workforce questionnaire that we compared to, but I'll come back to that in a moment. So here we go. The red bars are the FAPMI regions, the blue ones are the non-FAPMI regions, and this is the number of referrals over time from mental health services to family services. Now this child first term, it's really a holding house or an assessing house before child protection. So there's adult mental health services here, there's child protection over here, and there's a new invention that came in 2007 as well that's called Child First. And it's really, well, I'm worried about this child, I want to refer them out to Child First. They'll be assessed there for whether there's major issues in the family or not. You know, the children are really at risk. About 20% of those referrals get then transferred onto child protection, all right? So this is important data. It's how many are transferring out. As you can see, the FAPMI regions, it's going up. And that's great. It's fantastic. Sending the kids out to get more assessment. Often it's not out of child protection thoughts. It's about how can the family get more help? How can the children get more help? How can there be more parenting help? So it's not negative, if you know what I mean. It's often good stuff. Not really changing in the non-FAPMI regions. And then this is...
How are the parents viewing their children being referred out?
Well, it's not necessarily the child. This is anything. It could be children getting extra services, the family getting extra services, the parents getting extra services. And to be really honest, the data is not broken down well enough.
Okay.
You know, it's online data that's collected about everybody across the service.
Okay.
Like we're talking about across 50,000 patients, you know, this data stuff. So now we're going to talk about the other way. How many referring from Child First back? So we're thinking Child First is saying this family's got a mental health problem, I'll refer them to mental health services. Absolutely no different. And you probably wouldn't expect anything different. Do you know what I mean? So absolutely no difference. But what do we see when we see the family contacts over that time? So we're back at adult mental health services now. How many times is the clinician in the FAPMI regions having family contacts and in the non-FAPMI regions having contacts, and what's that change over time? Well, here we see the non-FAPMI regions, the number of family contacts actually increases. All right, so there's actually increased numbers. But interestingly, remember the FAPMI regions are referring more people out. We see the reverse. We see the FAPMI regions and FAPMI coordinated regions, they're actually doing less. So they're actually doing less face-to-face with families, but more transferring them out, which is quite interesting, we thought. What that means, we don't really know. We think it's a bit, well, in Aussie rules terms, handballing the problem out to somewhere else. That's a negative, really negative view of it. The reason why the other's going up, it still is a statewide strategy. So the strategy is still there, there's just no workers in some regions. So you've got to be more family focused. So we think this increase, do you know what I mean? So you go, which is better? Do you know what I mean? Something for you to ponder on, and we are pondering on that as well. It did make us go, well, are you better to have experts that are outside of the system and that they just manage this stuff and that adult mental health can't manage this stuff? You know what I mean? Back to my ideas of confidence and skill and knowledge early on. Don't know. We then did a study of the FAPMI coordinated adult mental health services and the non-FAPMI. You don't need to know a lot about this, but we had quite small numbers in non-FAPMI. So we had over 43 clinicians in non-FAPMI regions and 40 in the FAPMI regions. And we looked at them in terms of a workforce practice questionnaire that we'd developed. Now it's around things like, what sort of workplace support do I get for my family-focused practice? Do I want professional development in the area? Do I want more training in the area? What skill and knowledge do I have in the area of family-focused practice? You know, can I assess the impact on the child of the parent when they're sitting in front of me and so forth? The red bars is the FAPMI coordinators, coordinated regions. So this is like 5 years later. After having the 5 years worth, this is the change in skill and knowledge, particularly around here. They're clear skill and knowledge areas and significantly better off. The FAPMI regions are significantly better off in terms of skill and knowledge around family-focused practice compared to the non-regions. There's a couple of other things down here as well. So there was actual change in that in terms of having a FAPMI coordinator. So it seems to work. Where to now? We think it should be more about, and it's more about what we're doing and what resources we've got, of actually focusing training on adult mental health clinicians about an actual intervention for parents. Let's Talk is what we're using, a Finnish version, but Bill Beasley's equally okay. I will leave you with something though. This is, I would never write this about 2 years ago, but I think if you're in the psychiatric workforce or you know somebody, pass on this message for me. I don't think it's any longer okay or ethical to say, I don't know if they're a parent or not. I don't think it's okay to say, I don't have time to work with parents, family and children. I don't think it's okay to say, we don't have the resources. And I don't think it's okay to say, particularly in English countries, that I don't have the knowledge or skills, because there's an online resource in Australia that you can go on and get that knowledge and skills. That's my final message. That's my grumpy final message.
Is there a particular curriculum that is used with the families that's been developed?
Well, I guess there's two things to answer your question. The National Children and Parents with a Mental Illness Group, who Phil and Nick are presenting tomorrow on the whole strategy. There's on the COPMI website, and all you need to do is Google COPMI. You'll get to the website. There's many things, but one of them is a thing called Keeping Families and Children in Mind, KFC we call it, to fit the chicken and acronym. But it's really basically a 6-session free online training package to upskill you in terms of the basics. Then there's, how many sessions, Bill? Is it 6?
Yeah.
For family focus, it's called. And it's a training program in Bill's model. If you do both of those, I think you'll be a fair way along the road of...
And ours is available online at fampod.org.
Yeah.
What is it?
Do you want to say that again?
fampod.org.
Fampod.org.
Available for free.
I work a great deal with David O'Connell and Gwyneth Llewellyn and other researchers that are Canadian-based, but previously were Australian-based or are still in Australia. And I know that the parents with intellectual disability community has followed a very similar time trajectory in rolling out federal programs. Is that somehow tied to a central funding initiative? How is it that you both sort of began this sort of copious amount of work and resource building and online access and peer support and expert capacity building at the same time?
Well, I would guess they're funded from exactly the same source, the Department of Health.
Department of Health.
Yeah, Department of Health and Ageing that it was.
Was there something that occurred in Australia particularly, like, in the last decade that promoted this?
I think in the background of all this, and there's been talk of this elsewhere about stigma and so forth, there's been a hell of a lot of stuff around stigma reduction in Australia, and that's got to go hand in hand with all of this, I think. You know, that's really, really important. But I think in Australia, what happened with that, there's been whole lots of politicians, sporting personalities, media personalities coming out and saying, I've got depression, I'm going off. And every week you'll now see a football player or a politician or this cricketer went back to England recently, you know, like I'm taking time, I have to take time off, I can't. So people are going, oh, he's depressed, oh, he's got a broken leg. So that's hopefully what's happening, is that mental illnesses are destigmatised, yeah. And that's going on at the same time, I think, with intellectual disability as well.
You guys are just amazing.
She was first.
Okay.
Sorry.
Just a quick question. In Melbourne, I think, Canada, there's a program called Wellness Works. Do you know anything about that program? That's a program that goes into the workforce and supports parents who have challenges, mental health challenges, as well as parents or caregivers of children with challenges, and how to adapt their workforce for them to keep their jobs.
I'd like to know more about that.
I can give you some information.
Yeah, no, that'd be really good.
It's a great supportive program.
Good, good.
Did you find that 15 to 10% of the clients have children? Was it in the first slide?
In adult mental health services,
yes.
It's around 19 to 20%.
Then Joanne Nicholson found in the United States it's about 60 to 67%. And in the Netherlands we found about 50%.
Yeah, okay.
So do you know an explanation for these big differences?
It's, no I don't.
And UK it's about 50%.
Well, this is certainly from our data from the state, the statewide data set. But certainly our prevalence data that we've put together says it's between 20 to 23% of children grow up in families with a parent with a mental illness. So no, I can't.
Research for that, I guess.
I think it's a different question. Yeah.
Well, I think it's similar because in Canada, one of the things, and this is anecdotally, and I work with parents that have mental health issues, and why they say that they are not connected to adult mental health services is because they don't see them as a family. So they treat their symptoms independent of being a provider of care for children, and that symptom reduction often is medication, which incapacitates them from parenting. So what they do is they disengage from adult mental health services. So you might not see that representation of people with kids in that adult mental health system because they don't get support from a family perspective.
And maybe we're underrepresented. I don't know.
These are research to the whole population, so this is only what comes there. But what I'm talking about is the whole population.
Yeah, okay.
I'm curious, you touched on a little bit talking about community. And I work for a community nonprofit organization, and what we really see is we do a lot of outreach work, and we work with a lot of families where parents have mental illness. I happen to work with also kids with special needs. But I'm curious because I think in your last presentation you said that the percentage of maybe just parents who are sick enough to ways that accessing adult mental health, but I see this huge population that doesn't seem to be being reached. And I wonder,
There's the numbers I'm presenting here, the 50,000 out of 5 million, I think, are in, and I think the numbers are something like only about 20% of people actually go for treatment for their mental health problem. There's 80% they just don't go anywhere. They don't get any particular what we would call treatment, whether they're getting support and so forth from other sites. But so the numbers here are those only receiving treatment. There's that whole other group out there besides it. We know in Australia that I think it's 10 million visits every year to general practice, to your doctor, for mental health problems. It's 1 in 10 visits to a general practitioner for mental health concerns.
I'm just wondering about linking, especially with family work, linking or sort of community more with, health services or health authorities, and how maybe prevention, particularly for family, is a big opportunity.
I think so, and certainly adult mental health, that's a lot of their challenge. They're usually a pretty closed book. The thing is that they've got to be the reverse, because you can't do family work in a closed book, you know what I mean? And that's sort of a bit what Madada's talking about, I think. Sorry, you had a question.
You mentioned that there were resources, but they already mentioned the fund. Are there other websites where we could access information?
Well, certainly the Cockney website in Australia, but FAMPOD, as Bill was saying, here in the US, but Cockney in Australia is lots of different booklets and things you can download and online training packages, and the online training packages are just state of the art. Really, really good stuff.
You had mentioned this morning that there's the online component, but then there's also a half-a-day session that you would do with people in person.
Yes.
What is covered in that half-a-day session?
It's more getting people to talk about their experience. Some of it, what some groups try and do is actually bring the community adult mental health and rehabilitation sectors together and be trained together, and I find that works really well for bringing out adult mental health and bringing the two together. So there's sort of some of the aims of that. But it's to get people talking about their practice. The aim is to then often have follow-up sessions where people go and try it, come back, this didn't work, that worked, how can I do this better, and sharing information.
Is there any resources online that kind of outline what that day might look like?
The Bouverie Centre are the people to talk to, and I can give you the name of somebody who could really help you out. Rose Cuthbert, Brendan O'Hanlon.
So if we, one more.
When you talk about adult mental health, you're talking about public mental health, right?
Yeah.
And so have y'all done anything with private practitioners? In private practice?
No. But that's our next frontier.
Okay.
In Australia, there's a whole lot of services that flow from general practice, and psychologists, social workers, psych nurses work from those. That's our next challenge.
So on that note, thank you very much, Aaron.
Yeah.